I think it's fantastic that the RCN's addressing the issue of parity of esteem at the moment. But one of the really important things that we need to do as we embark upon this work is to really try to understand parity of esteem and what that means in the mental health environment, so that we can look and understand about something of the behaviours that have led us to the position that we're in now. And if we look at how we've managed mental health services in the UK, after the war, we adopted a strategy of institutionalisation, whereby people with serious mental illnesses were put in sanatoriums, were put in long-stay psychiatric hospitals, and they were treated in those hospitals with a new generation of drugs called the phenothiazines, which were a very, very toxic group of drugs that made people impotent, that had terrible consequences on their physical health, that isolated them emotionally and psychologically from the world and the families that they had previously been part of. And that strategy stayed with us until the 1980s. And that strategy was running completely contrary to what was happening in other areas of healthcare. So, for example, if you look at child healthcare in the post-war years, we saw the closing down of sanatoriums. We saw the healthcare of children becoming much more community-based, becoming involved in general practice, and really owned locally, which was something that didn't happen in relation to mental health care. Things got compounded even further as we follow the history after the war. In the 1980s, we had the HIV/AIDS concerns emerging across the world, not just in the UK. And our response to that was very, very different to what we've been doing in relation to mental health. We even had Norman Fowler, who was then the Secretary of State for Health, making absolutely brilliant TV commercials to try to get the population to understand what was happening in relation to HIV and to stop speculating and fantasising about some of the aspects of HIV. So we saw ownership of the HIV/AIDS issues at a very, very high level in government, something that was completely unknown for us in relation to mental health care. What did we do with mental health care at the same time that we were doing that with AIDS? We actually decided to adopt a strategy whereby we disinvested in mental health services. We said that it was wrong to keep people in institutions and that stigmatised them. And that's where we find ourselves now. And as we tackle parity of esteem, we really need to understand what we're doing in the context of the history of the last 50 years or 60 years around mental health care in the UK. And that disinvestment in mental health services at the end of the last century leaves us with many, many of the consequences that we need to deal with through our Parity of Esteem programme now. And that disinvestment was very, very significant. That disinvestment meant that we haven't properly, at a fundamental level, addressed the primary healthcare needs of people with mental health problems. So we have a population of people who've had a tendency to smoke, who've been on very toxic medication, not getting the proper screening that they need for physical health problems. Massive deficit there that we need to pick up and address. But particularly in terms of the social support of people and the integration back into communities and people understanding that, and people seeing mental health problems in the same way that they see physical health problems. Just as that work took place around trying to understand AIDS in the context of the wider health agenda, a lot of that work hasn't been done. And that's what Parity of Esteem, our Parity of Esteem programmes really need to enable us to catch up on that now.